recap certain things. So last time when we started CNS, we said there is a balance between excitatory neurons and inhibitory neurons. The neurons, they are same and they function same, but the neurotransmitter that they release is different. So on the basis of this neurotransmitter, we call a neuron excitatory or inhibitory. But the function or the physiology behind everything is the same. But certain neurotransmitters, if they increase the influx of negatively charged ions, influx that means inside the cell, if some more negativity is happening inside the cell, that means the cell is not firing, the nerve is not firing. So the neurotransmitter that causes this are called as inhibitory neurotransmitters, and the nerves releasing these neurotransmitters are called as inhibitory neurons, and it's vice versa. If a nerve is releasing a neurotransmitter that increases the influx of positively charged ion in another nerve or in postsynaptic nerve, that means there is going to be firing of the postsynaptic nerve and the signal will pass on further. So these neurons are called as excitatory neurons. So in a normal state and in a healthy patient, the excitatory neurons and inhibitory neuron firing is in balance. If anything changes, if there is increase in inhibitory neurons, if there is decrease in inhibitory neurons and increase in excitatory neurons, these conditions, they causes mania kind of condition or psychosis. If we have increase, anybody wants to say anything? Okay. If the excitatory neurons or there is decrease in excitatory neurotransmitter, there is increase inhibitory activity, which leads to um, decrease activity throughout the body. Like if there is excessive depression, then it can be physical and emotional both. And in cases of overdose of certain drugs in CNS, and if they are inhibitory kind, so there is decreased activity of certain processes in the brain, which leads to their effect on the physical process. So most of the patient who die with toxicity of any inhibitory drug, they die because of respiratory depression. And why is that happening? Because inhibitory neurons in brain are firing more, which leads to decrease in any physiological process. And the first one that causes the death is respiration. So this is a basic principle behind the drugs that we discuss. Any neurological condition that is caused by hyperexcitation of the neurons, we give inhibitory drugs. If a state like depression is there, when there is excessive inhibition, we give drugs which are causing excitation. And the drugs are actually acting similar to the neurotransmitter. So for excitatory neurotransmitter, we have dopamine, epinephrine, norepinephrine, serotonin. For inhibitory, we have GABA, and today we are discussing mainly about GABA. So, again, briefly, I'm talking about the same thing. So, when there is a firing of one neuron, that means there is excessive positivity inside, or the sodium channels open, and they lead to excessive influx of the sodium inside the cell, which increases the polarization. And when we put the graph, this is called as depolarization. So you see here is the current, so it increases towards positive. And at one point of time, it when it fires, when we say fire, that means the positivity inside is so much that the cell is gonna release its content. And when it releases its content in the synapse, it leads to opening of these channels, the postsynaptic nerve. When these channels open, there is influx of further positively charged ions, and this leads to excitation of the postsynaptic neuron. So this is an excitatory kind of uh, firing. But the brain has some neurons that they are releasing neurotransmitters that are inhibitory neurotransmitters, and that is GABA. And what does GABA do? It opens a channel that is specifically for a negatively charged ion, and that is chloride ion. And there is influx of negatively charged ion inside the cell. And what happens? So when there is excessive negativity inside the cell, the resting potential of the cell, it decreases. So if this is zero, so it becomes say minus 60. So to fire this neuron, which is at minus 60, you need to have a lot of positive ion inside to do its firing. So it is kind of decreasing the threshold. And this is the principle of, or the mechanism of action of benzos and barbs that we are going to discuss today. So this GABA receptor, when it opens, there is influx of chloride ions, which increases the negativity inside the cell. Hence, it decreases the threshold. I'm sorry, it increases the threshold. And we need more positively charged ion, or we can say we need more firing uh, to create a action potential in the postsynaptic nerve. And this is how it causes inhibition. So at a normal state, this excitation and inhibition is at balance, and it is controlled by various systems that are there in the brain. And we discussed those mesolimbic, nigrostriatal, and infundibular, and so on. So they always keep a check on the levels of firing of the nerves that are present in the brain and spinal cord. Okay. So the first category in CNS that we are talking about today is bipolar drugs. Not much to discuss about this. When we say bipolar drugs, the only drug that we have to remember is lithium. So bipolar disorder is such a state when this is the okay, so this is the excitatory. It should be in balance, excitatory and inhibitory. But in bipolar disorder, it can go excessively like this or like this. So there are phases, different phases of mania and depression. So patient can actually go from excessive mania to excessive depression. So the drugs that we discussed before, they were anti-epileptic, anti-psychotic, anti-Parkinson's. So they were stopping some excessive firing of either excitatory or inhibitory. But here, the drugs that we give, they have to maintain the balance because the patient can go from excessive excitation to excessive inhibition. So the lithium is the drug that are used for bipolar disorder, and this is the first line of treatment, and most importantly it is used for suppressing the mania, excessive mania, or and it cannot be given in acute cases. If a patient is in acute state of mania, we have to give antipsychotics. We have to immediately stop the excitatory pathway that is active in the brain. But in cases of chronic mania, lithium is the drug of choice. And how does it work? It is actually, so this is the cell membrane. So when there is action potential that travels, there is opening of certain receptors, and these receptors there is influx of certain ions. So these receptors can vary from different nerve to different nerves. Some are like that, the neurotransmitter attaches here, which opens this receptor and the ion goes in. Some sub receptors are like that, for example, G protein coupled receptor, that it attaches to uh, the receptor, and it leads to certain configurational change in the receptor, which is sensed by the things that are present in the cytoplasm, and they causes um, activation of a second messenger, for example CAMP. This CAMP, when it senses that the signal has been transmitted by this receptor, it becomes active, and it goes and causes its reaction within the cell, whether it has to cause protein formation or inhibition of some process. So this goes and act on the inside of the cell. So lithium actually, it prevents the formation of the process that is activated by second messenger. So lithium goes and it goes in and stop this area, and the process that is activated by this second messenger stops, and this maintains a balance between depression and mania. There is no set dose of lithium, it is dependent on the patient also, and at what level um, a balance is maintained, and it is different in every individual. So this drug is actually working inside the cell, and it is preventing the formation of a second messenger, and this influences the nerve activity, and hence it can prevent both depressive and mania states. And in mania we are talking about chronic mania only. But lithium, it has side effects on almost all the systems, on CVS, kidneys, brain. Obviously, it is, that's the effect that we want. Skin and thyroid, and most important to remember, it gives metallic taste. So metronidazole, lithium, and barbs, they are the drugs that can have metallic taste as their side effect. So the kidneys are at risk because lithium is eliminated via kidney. So the kidney damage can be a side effect, and there can be severe intoxication. So they have to monitor the blood levels of lithium to prevent the toxicity. If there is toxicity, there can be severe diarrhea, vomiting, drowsiness, muscular weakness, because it will depress everything. So there is muscular weakness, drowsiness, and lack of coordination and convergence. Thyroid function can be altered, but it happens approximately after 1 year of therapy of lithium. And we also see dry skin, bradycardia, constipation, hair loss, and cold intolerance due to its effect on thyroid gland. This should be avoided during pregnancy, and in patients where we have sodium restricted diet, it's gonna retain the lithium also. So excessive lithium would be there in the blood, and this is contraindicated with patients taking diuretics and non-steroidal anti-inflammatory drugs. So this was all about bipolar disorder and drugs used for this. The next class.
Hi, doctor. Your audio is off. It's showing that your account that transmits the audio was logged out of the class. So we can't hear you.
Can you hear me now?
Yes, yes. Now,
I'm not sure what happened.
yeah, it was saying you logged out of the class, the other account, but we can hear you
Yeah,
now.
yeah, yeah. Okay. I mean, I don't know how it went off. Okay. So, we you were able to hear me during this, right?
Yes, yes.
Okay, cool. So, antidepressants, the drug itself is telling the balance is disturbed and there is excessive depression. So, there is excessive inhibition, and these antidepressant drugs, they either reduce the inhibitory neurons or they increase the availability of excitatory neurons. The major principle behind the drugs that are used for as antidepressants, it is increasing the effect directly or indirectly of excitatory neurotransmitters, and they are dopamine, serotonin, also known as 5-HT, and epinephrine and norepinephrine. So these neurotransmitter are excitatory neurotransmitter, and they are the target of these antidepressant drugs. So here I would like to discuss three major class of antidepressant drugs. Let's name first, and then we will see the physiology. MAO inhibitors, monoamine oxidase, that's an enzyme, and we discussed this before also. Tricyclic antidepressants. They are named so because of their chemical structure. It has tricyclic or tribenzene kind of a ring. This is not the right structure, but this is what it means. And SSRIs, they are serotonin selective reuptake inhibitors. So the name is explaining everything here. They are selectively binding to the serotonin receptors and they are affecting its reuptake. So before we see each class, I would like to discuss the formation of neurotransmitters again. So I'll make, okay, let's do like this. So we discussed the formation of dopamine before also. Actually, twice we discussed this. So there is an amino acid called tyrosine or tyrosine. This is converted into L-dopa, and this L-dopa is converted into dopamine, and it can be converted, dopamine can be converted into norepinephrine, and these neurotransmitters, they get stored in vesicles to be available at the time of need. So in dopaminergic type of nerve, dopaminergic, the cycle stays up till here, and in adrenergic or noradrenergic type of nerve, it converts into norepinephrine. So these neurotransmitters are available in the vesicles, and when there is excitation or when there is influx of sodium inside the cell, these vesicles, sodium and calcium actually both, these vesicles, they open and they release the neurotransmitter in the synapse, and there is postsynaptic nerve, and dependent on the type of neurotransmitter, we have receptors here. For dopamine, we have dopaminergic receptor D1 and D2. And for adrenergic type of nerves, we have alpha and beta, alpha 1, alpha 2, beta 1, beta 2. So these are different receptors and they are present throughout the body. And these agents, L-dopa, dopamine, epinephrine, norepinephrine, they have effect on almost all the systems, and they have different effects on each of the system. So this is a normal cycle. So once the this neurotransmitter is released, name it dopa or epinephrine. So these, when they activate the receptors on the postsynaptic nerve, they have to go back to the cell. There is recycling. So there are gates available here for reuptake. In adrenergic, if you remember, we had alpha 2. Alpha 2 receptor was present on the presynaptic nerve, and this was going and it was telling the presynaptic nerve not to release further. And in dopaminergic type of nerve, there is uh, these channels that are taking up the dopamine again, and it was either degrading the dopamine or it was storing back in the vesicles. And what were these things? So they were Mao and Comte. So Mao was outside, Comte was inside. So here Mao is important. It is monoamine oxidase enzyme. So it is oxidizing a substance which is an amine in nature, a protein in nature. And you see, tyrosine is a protein, and there is a reaction happening here, and the resultant, the neurotransmitter, is also a type of protein only. So this MAO, it eats up this neurotransmitter, and the byproduct was is sent to the cell again for recycling. So this is the whole process of excitation and uptake of the neurotransmitter. This is what we discussed about dopaminergic type of receptor. When we see a nerve that is a serotonergic receptor nerve, serotonergic. So the concept behind the excitation of nerve and release of neurotransmission is the same, only the neurotransmitter is different. So in dopaminergic and epinephrine type of nerve, we had tyrosine. Here we have tryptophan. I don't think it's important to remember. And the reaction happens and it is converted into serotonin, and it is stored in the vesicles. When there is excitation of this nerve, this serotonin is released in synapse and it excites the postsynaptic nerve, which has serotonin receptors. And here, the gate that is present is called as serotonin reuptake channel, and the extra serotonin goes back. So, antidepressant drug is increasing the activity of the brain. As we said, when there is depression, that means either there is excessive inhibition or there is less excitatory neurons. So, the principle behind anti depressant drug is to either increase dopamine, increase serotonin, or increase norepinephrine. And the drugs that are under this category, they are doing this only. When we say MAO inhibitors, so MAO is the enzyme that is eating up the neurotransmitter. So when we are inhibiting that enzyme, there will be excessive. Um, I shouldn't be saying excessive. There will be relative increase of uh, neurotransmitter present in the synaptic area, and that can fire the nerve again and again. Tricyclic antidepressants, they are actually affecting all three. They are affecting the dopaminergic receptor, they are affecting the adrenergic and the serotonergic receptor, both. I mean, all three types of uh, nerves, mainly serotonin and norepinephrine. And serotonin selective reuptake inhibitors, it's active only on serotonergic receptors or serotonergic nerves. And what is doing? It is blocking this. So this is the serotonin reuptake transporter. It is blocking this, therefore there is excessive serotonin present here for firing of the postsynaptic nerve. So this is the principle behind of all these antidepressant drugs. They are making availability of neurotransmitter more so that there can be firing. Let's name the drugs under all these classes.
Hello, doctor. We can't hear you.
No, doctor, I cannot hear you. On my side, I hear nothing. No.
Oh, oh my god.
Now, yes.
Now you can hear me now?
Yes.
Yeah, it works
Oh
now.
my god. I don't know
Yes,
what's
okay.
happening.
Thank
This
you.
is creepy.
Welcome back.
Okay, thank you. Thank you. I was talking to myself. Okay, so what was the last thing that you guys heard? I didn't even see the messages.
Hi, Dr. Tanvi.
Yes, Dr. Kiran, how are you?
I'm good. How are you?
I'm good too. Yes,
How
please.
was your day?
Uh, funny. Yeah, not bad, not bad.
Okay,
Just a
that's
little
nice.
crazy, yeah, but not bad.
It's nice you're working and studying together.
You guys are my motivation, you know. I feel bad when I don't study and don't come to class.
It's fine. It's your,
No, no, don't
hard
say that
work.
otherwise.
Yeah,
No.
it's really nice you're taking the classes.
Mm. No, it's good for me also, doctor. This is the reason I'm
See,
studying. Otherwise, I wouldn't have.
I am overwhelmed. Yeah.
I am overwhelmed with pharmacology and actually AFK altogether.
Yeah, true. It's
Yes.
been happening to us from really long
I
time.
know, it's been, I mean, more than a year. And I see
Yeah.
most of the students in our group, they were studying way before February 2020. So
You
it's
won't
crazy.
believe I failed once and
I failed twice, doctor. I can believe.
yeah, and it's a long journey for me,
That's right. Yeah, for
Yeah,
everybody. I really wish
yeah.
good luck to all of us.
I took exam in August 2019 and now it's 2021.
Yeah.
Yeah,
I hope they conduct the class. I mean, the
yeah,
exam.
yeah, hopefully.
Yes. Okay. So back
You,
to class. You tell
yeah,
me what was the last thing that you heard?
you were on the medicines, the for the antidepressants. Can you hear me, Dr. Tanvi? Hello? Hello? Kiran, I think she lost the connection again.
Can you hear me now?
Okay, okay. Yeah, yeah. Now it's fine.
I don't know what's
You are
happening. Yeah.
you are on the medicines
Me.
for antidepressants. Yeah.
Yeah. I am already sedated most of the day, so I don't think I should be in any medication causing sedation.
These are the antidepressants.
Yeah.
Yeah. Okay.
So I'm not
Thank
sure
you.
what's happening with the connection. So where were we?
You are on the medicines for antidepressants.
Oh, okay. So, oh, I'm sorry. I thought you were cracking a joke when you
No,
went that
no.
late.
No, seriously, you are on the medicines.
Okay, okay, okay.
Okay.
So, thank you.
Anytime.
So we discussed the mechanism of action of all three classes. I'm just gonna name some drugs under each class, but I think the most important to remember here is amitriptyline, because in most of the questions, when they give us case, there is they give us patient taking amitriptyline, so we need to know, okay, it's an antidepressant. Which type? It's a tricyclic type of antidepressant. So we need to know its um, side effects, or what are the possible actions it can cause. So in first category, that's MAO inhibitors. So these MAO inhibitors, they are preventing the reuptake, or they are preventing the kind of digestion for all these three neurotransmitter, and they act on all three kinds of nerves: serotonergic nerves, dopaminergic nerves, and adrenergic nerves. And the drugs under this class, I never remember these: phenylzine or phenelzine, isocarboxazide. And the mechanism of action is, by inhibiting this enzyme, they are increasing the levels of norepinephrine, serotonin, and dopamine in CNS. And do remember, MAO is present almost in other organs, everywhere in other organs also, like liver, the whole of GI tract. And that's the reason, if you remember, in anti-Parkinson's, we discussed that in patients we give L-DOPA, because L-DOPA, we cannot give dopamine because dopamine is going to be eaten up by MAO that is present in GI and liver. So that's why we give L-DOPA. And here MAO inhibitors are, the side effects are related to the extrapyramidal effect of the inhibition of this enzyme. The next important class here is tricyclic antidepressants. So their main action is on the serotonergic and adrenergic nerves. And they increase the levels of serotonin and norepinephrine by inhibiting the reuptake or by increasing the release. The drug under this class is amitriptyline. So it is important to remember its side effect, and the side effect that can be seen with tricyclic antidepressants are mainly because of its increasing activity of or increasing activity of uh, norepinephrine reuptake. The most common side effects are sedation. That's with almost all the antidepressants. There would be orthostatic hypotension, and dry mouth. Other side effects includes tremors, restlessness, insomnia. There can be edema, headache, and seizures, and blood dyscrasias. And another important is cardiotoxicity. So when we'll do the drug interaction, I have a table for cardiotoxic and hepatotoxic drugs. So we'll go through that again. And the SSRIs, their action is by selectively increasing or decreasing the reuptake of serotonin via the gateway that is present called as SERT. That's the transporter that is present in the presynaptic nerve that takes up the serotonin back. So now we are coming onto benzos and barbs. I would like to just discuss both of them together because they have similar actions. We'll see the name of the drugs later on. So when we say benzos and barbs, they are actually acting on an inhibitory type of pathway that is related to GABA. So if I make the cell here, the cell membrane, it's a nerve. So I'm making benzos here and barbs. So when we say GABA receptor, so GABA is an inhibitory type of neurotransmitter that is there in the CNS. And the receptor for this GABA can be of two types. It can be a ligand kind of a receptor or a G protein. If you remember, we said there can be four types of receptors. One was ligand gated. There is a site where a ligand can come and bind, leads to activation of the receptor. There is one as enzyme linked, and there was one G protein coupled receptor, the transmembrane 7 transmembrane receptor, and there was intracellular receptors that were present in the cell membrane. So these were four types of receptors. So for GABA, there are two types of receptors present: ligand gated type and G protein coupled. So when we talk about benzos and barbs and when we see CNS, they are acting on the ligand gated type of gamma receptor, and they are also called as gamma GABA A, is gamma aminobutyric acid A. That's a subtype. But I don't think it's so important. But the reason I mentioned it here is to understand of the process of its action. So this GABA receptor is actually a flower-like receptor, and it has five subunits. When we see from the top, I never make this right. When we see from the top, there are five subunits like this. So the two are alpha, two are beta, and one is gamma or delta. So benzos and barbs and GABA, they go and bind to certain areas of this receptor. This is from the top, and this is, if you see, in the cross section. And this is the central pore. When there is activation, the central pore opens and there is influx of the ions. And which ion it takes? It takes chloride ion. If you remember, it increases the negativity within the cell. So there are five receptors or five subunits here. So the GABA, it goes and it binds between alpha and beta here. And benzos and barbs, they are actually acting like GABA, and GABA is inhibitory. And benzos, they go and they bind to some other subunits. So let me make it red. Benzos are red.
Excuse me, doctor.
Yes, please.
Could you please repeat this? GABA will attach to which subunit?
Alpha and center between
Delta? Delta, gamma, or alpha and beta?
alpha and beta.
Thank you.
No problem, doctor. Okay, so I'm making GABA as pink. So GABA goes and its binding site is here. And benzos, what it does, benzos are red. They go and they bind to some other area. And what they do, they are not directly binding to the GABA binding site. They are binding somewhere else, which increases the affinity of this receptor for GABA. So if there is benzo that is acting here, this makes this whole unit more susceptible or highly efficient or highly effective for present GABA to act on this. And but barbs, making it green, barbs, they go and they bind to the GABA binding site only. The difference between these two is so there are five subunits. Benzos, what they do, they increases the frequency of opening of these receptors. So they bind to a site which makes it more efficient or effective or susceptible for GABA. And there is influx of chloride ion, and it increases the frequency of opening. But barbs, as they are binding to the GABA site only, they stay bound to this area, and they keep this one receptor open for a very long time. Therefore, there is excessive influx of chloride ion, and that is why their action is way long, and the therapeutic dose of barbs is way low. So, the difference between the mechanism of action of both is benzos, they increase the frequency of opening of the channel, and barbs, they increase the duration of opening of the channel. So I hope this is clear. So when we talk about benzos, their action is dependent on the amount that is given. So if we give excessive benzos, then the receptors that they bound, there is high receptor occupancy. And when there are more receptors that are affected by benzos, that means there is high affinity of almost all the receptors for GABA, then there can be severe depression of the CNS system, or we can have general anesthesia in higher doses. But in low doses, there is low receptor occupancy, and it produces anxiolytic effect. In medium receptor occupancy, it produces sedation, but the mechanism of action is the same. They go and they bind to the receptor, and they keep it they increases the frequency of binding of GABA, hence there is increased chloride ion within the nerve. These drugs, benzos, they are well absorbed orally, and they are highly lipid soluble also. So these highly lipid soluble drugs, they crosses blood brain barrier quickly, and their action of duration is short, and there is more rapid action also because they are lipid soluble, and it's easier for them to cross blood brain barrier. So they quickly go to the brain because they can cross the membrane, produces it action, and they can quickly come out also because of their chemical structure. So the drugs under benzos can be divided into three classes based on its action. So they can be long acting, intermediate acting, and short acting. In long acting, we have diazepam. In intermediate acting, we have lorazepam. So the long acting will have longer half life. Intermediate acting has intermediate half life, and short acting has shortest half life. And there is no active metabolite for these two classes. When we say active metabolite, I'll discuss in detail. Just a second. And short acting, we have triazolam. So any drug that is there in the blood, it has to go to the liver for its metabolism. So liver does phase 1 reaction, that can be simple reactions to make drug non-polar or non-lipid soluble, and these reactions can be oxidation, hydrolysis, reduction, and so on. And then these drugs, they go back to blood. So those who are, the drugs that are converted into water soluble compounds, they are excreted out from the kidney. But if something is still active, in example, we have all the benzos, they are they are still active, most of them, and they go and stay active in the blood, and they lead to second sleep effect. What does that mean? As their metabolites that are being converted by liver, the first metabolite, let's take example of diazepam. It has no. Let's take example of triazolam. So triazolam, after phase one reaction, it converts into its hydroxyl derivative. There is hydrolysis that happens to the compound, and they go back to blood, and it still stays active. And this active blood, the active metabolite that stays in the blood, will cause its effect again. So it goes to brain, and it causes blood brain barrier, and it has its effect, which leads to second sleep effect. And this is mainly seen in long acting type of benzos. And then this compound goes back to blood, and then it goes to liver. Now liver senses that now we have to do something big with this to get this metabolite out of the body. So what it does phase 2 reaction, and in this case we have glucuronidation. It's like detoxification of the drug, and then it is sent to the blood and then excreted out from kidney. So this is called as second sleep effect, or it has most of the benzos, they have second, or their metabolite is also active, and that's why they have different time of action. If more stronger the metabolite, longer will be the effect. And these drugs are most commonly used for um, as anxiolytics. They are used for sedation and insomnia. It shows some anticonvulsant effects also, and can be used in epilepsy, mainly used for status epilepticus. It is used in cases of alcohol withdrawal, but it should never be combined with any other CNS depressant like alcohol. And muscle relaxation, because it is decreasing the activity, and there is everything is mediated by the brain. So if there is decreased activity here, it has its effect on the other parts of the body also, and there can be a generalized motor relaxation because of its effect on the brain areas. So it can be used for skeletal muscle relaxation. And because of its depressive effect, we see certain adverse effects also on respiratory system. If it is normal dosing, it doesn't show a significant depression, but in higher doses, it can depress the hypoxic drive. And hypoxic drive is necessary, so it is a concern in patients with COPD and obstructive sleep apnea. On CVS, when it is given in regular doses, there is again no significant depression, but at higher doses, it can decrease blood pressure significantly, and hence increase higher heart rate. And on eye, it can produce diplopia, nystagmus, blurred vision, and increased intraocular pressure. And for us to remember the side effects of benzos, they are xerostomia, swollen tongue can also be seen, and metallic taste. It's rare with benzos, but it is there. So three drugs that causes metallic taste are metronidazole, lithium that is used for bipolar, and benzos. When compared to barbs, benzos have a wide therapeutic index, but still, in cases of overdose, there is its antidote, that is flumazenil. It is used to treat overdoses because benzos they have possibility of dependency or abuse. The contraindication for these we have already discussed few: obstructive sleep apnea and severe COPD patients because of its action on the hypoxic drive, myasthenia gravis patient because of its action on muscle relaxation, and in glaucoma because it increases the intraocular pressure, so it's going to worsen the glaucoma, and it should be avoided in pregnancy. And in bars, we know the mechanism of action now. It binds to the GABA receptor and it increases the transmission of chloride ion. It increases the number of chloride ion that is being transferred uh, through that channel. The drugs under this class can be categorized into ultra short and long. So, one thing, because of its mechanism of action or the way it is acting, it is going and directly binding to the GABA receptor and keeping the receptor open, the central core or pore open for a very long time. Their therapeutic index is low and there are chances of overdose. So, any minimal increase can be lethal here. So when we say ultra short acting, any drug which is acting fast, that means it is highly lipid soluble. And the drugs under this is phenobarbital in long acting and thiopental in short acting. So thiopental is still used. Other drugs are not used anymore. I mean, they are used, but not for antidepressants or for sedation. Thiopental is used in induction of general anesthesia. And as they're ultra short acting, they go easily and they produces its action in the brain quickly, and it also exits rapidly because of its structure. It crosses the membrane quickly and comes out quickly. But they have very narrow therapeutic index, and slight overdose can be lethal here. So that is why benzos are preferred over barbs because they have less extrapyramidal effect, they have less profound depression of CNS systems, and the benzos they have larger therapeutic index. So other drugs in CNS, they are buspirone. It is used as an anti-anxiolytic drug. I'm sorry, anti-anxiety. And the mechanism of action is it goes and it binds to the serotonin receptor instead of GABA. So they have affinity for serotonin receptors. The other agent discussed here is chloral hydrate. And it convert it metabolites into an alcoholic or phenolic compound, and this phenolic compound is actually decreasing the activity of a lot of systems including cardiac system, and it decreases the cardiac contractility, and due to its excessive adverse effect, this is not used anymore. And others are, so when we discussed benzos, barbs, and there was non-benzose derivatives also, or non-benzose uh, receptor agonist too, to decrease the side effect of benzos. And barbs we know is, due to its low therapeutic index, it's not a safe drug. So they made non-benzose benzodiazepine receptor agonist. So they have little effect on the sleep cycle, but uh, they are used to treat insomnia because they have potential to cause physical and psychological dependence. These drugs are also under the controlled substance. And also, Dr. Mohammed shared a question regarding the list of controlled substances. So, most of the drugs that are causing sedation are actually under the controlled substances, but I have a list that I'll share again. So, these non benzos type of compounds, they have similar actions to benzodiazepine, but their chemical structure is not as benzodiazepine. And they are used in treatment of insomnia. And the effects are similar here, like benzos. We have neuromuscular incoordination can be there. Patient may have confusion. There is sedation. Obviously, there is sedation. These are all given for sedation. But benzos, there can be CNS depression altogether, so they are not safe. But with benzos and non-benzos receptor agonist, there is sedation only. So that will be all for today. Tomorrow we will do sedation as whole, and we will talk about antihistaminic, antiemetics, and other miscellaneous drugs. If you want me to repeat anything, please do let me know.
Thank you so much, doctor. I appreciate that.
No problem, doctor. Thank you very much.
I appreciate it. So the table that you said about
You remember I shared the, yeah, that.
Yeah.
So it has a table.
Oh really?
Yes, it has that article. It has a table. Somewhere I
Okay.
have written the drugs that we are familiar with. I'll look for it and share.
Please, and
Yes,
thank you.
please. No problem, doctor.
Appreciate that. So this one is nobody recorded today, right?
I'm not sure. Maybe Dr. Lisa did.
Okay. Thanks again. Have a good night, and
You too, please.
you're gonna sleep now, huh?
Yeah, and sometime, yes, I will sleep.
Enjoy the night. Thanks again.
Okay, doctor. Thank you very much. Have a wonderful night.
You too. Bye bye.
Thank you.